broadcast is now starting. All attendees are in listen-only mode.
Hi, good morning, everyone. Today's Thursday, September 3rd. I'm Donna Will, Professional Development Coordinator for the Developmental Disabilities Administration. We welcome you to the Waiver Amendments number 3 presentation. We have several presenters today. Patricia Sestoki, Director of Programs, Rhonda Workman, Director of Federal Programs, and Valerie Roddy, Director of Fiscal and Operations. Before we begin, I'd like to go over a few things about the webinar. All participants are in listen-only mode. There is a handout for the webinar, and you can find it in the handout section on your right, and we'll also be putting them on the website. We will be taking questions, and you can type those in the question or chat box, also in the panel to your right. And I think that's about it. Okay, so now I'd like to introduce Patricia Sestoki.
Thank you, Donna, and good morning, everyone. Just wanted to take this opportunity to thank all of you who are joining us this morning and to hearing DDA's proposed Amendment 3. We have been working very hard with Rhonda Workman and Valerie Roddy in really getting everything that we need to do to make sure we get this amendment up and running. And so again, this is a proposed, and Rhonda is going to talk a little bit about all the different areas that we're looking at, the public comment period and next steps, and then Valerie is going to talk to you about Appendix I and J. So I'm going to turn it over to Rhonda.
Thank you, Patricia. Next slide, please. So today's purpose, we're going to share some updates on LTSSMaryland Transition. We're going to share the purpose of Waiver Amendment number 3. We're also going to share some examples of language being added, reorganized, and some proposed changes. And we also want to share information related to the public comment process. Next slide. So first, we're going to begin with an introduction to our waivers just to make sure that we're all on the same page. Next slide, please. So the DDA operates 3 Medicaid home and community-based waiver programs. It includes the Family Supports Waiver, which currently supports children birth to 21 years. It includes a variety of our support services, and it includes an initial service cap for waiver enrollment of $12,000 annually. The Community Supports Waiver is our second waiver that supports both children and adults. It includes our Meaningful Day and our support services. And for initial enrollment, there is a service cap of $25,000. For our Community Pathways Waiver, it supports children and adults. It includes all of our Meaningful Day services, our support services, and our residential services. Requests to make changes to waiver programs are made by submitting a waiver amendment to the Federal Center for Medicare and Medicaid Services, and that's what we're going to be talking about today. Next slide, please. A federal waiver program, the actual application for our family supports, community supports, and Community Pathways Waiver is composed of multiple appendices as listed here on the slide. There's a main section which will give an overview purpose of the program or the amendment and includes any required transition information. Appendix A provides information about the waiver administration and operations. It'll describe information related to our Department's Medicaid office, the Office of Long-Term Services and Supports that is ultimately responsible for the program, and then DDA's role as the day-to-day operating agency. Appendix B is specific to participant access and eligibility. In this section, you're going to see information about the targeted group, such as individuals with developmental disabilities, number of participants that we propose supporting, sometimes referred to as slots, also requirements related to the Medicaid financial eligibility, and the level of care, or known as LOC, related to meeting an institutional need for services for an intermediate care facility for individuals with intellectual disabilities. Appendix C is probably the largest appendix. It includes our participant services. In this section, you're going to see information related to each service scope, requirements, if there's any limits, service delivery models, such as whether it's available under our self-directed model or traditional model, and also includes the specific provider qualifications. Appendix D is referred to as the participant-centered service planning and delivery. Here you will see information related to the person-centered planning process and the roles and activities that our coordinators of community services, DDA's case management entities, in terms of that person-centered planning process. Appendix E is related to participant direction of services. In Maryland, we refer to this as our self-directed service delivery model. This appendix includes the specific services that are available as an option for self-direction. It'll note the different types of self-direction authorities, meaning employer authority or budget authority. It talks about the process to access this service delivery model and also includes information related to voluntarily or involuntarily discontinuing that service model. And then Appendix F provides information about our participant rights. This is where you'll see information about Medicaid hearings, CRCs, which is referred to as our case resolution conferences, and also information related to complaints and how they're submitted and how they're processed. Appendix G relates to participant safeguards. Here you'll see information related to medication management, restraints, and restrictions as we have related to the state of Maryland's Code of Maryland regulations and policies. Appendix H is a very small appendix. It gives a very brief overview of the quality improvement strategy related to the program. Appendix I is referred to as financial accountability. Here you'll see information related to payment methods and audits. And then Appendix J relates to our cost neutrality demonstration. Appendix K will provide a 5-year purview of projected users of each service and average units and average cost associated with them. Next slide, please. So let's start to talk about the purpose. Next slide, please. So Amendment number 3, 2020, purpose is to update the LTSSMaryland Transition, which we had noted in Amendment number 1 and 2, to update our waiver program application language, to reorganize information for better understanding, to update our program slots and streamline our eligibility, to review and enhance service options, and to update rates, units, and add a geographical differential. It's important to note that this amendment does not supersede the existing Appendix K, Emergency Preparedness and Response, that we've received approval from CMS. Rather, this amendment is to change the existing authority so that when Appendix K is no longer in effect, this amendment will continue to apply. Next slide, please. So now I'm just going to preview some information about the different sections that we reviewed. So let's talk a little bit about what you're going to see in the main and Appendix A section. Next slide, please. In this section, you'll see some information about our update to our transition to LTSS Maryland. Until services are fully transitioned under LTSS Maryland, participants will receive a combination of new services and equivalent legacy services to ensure that those needs and preferences, as documented in our person-centered plan in LTSS, are met. Until the DDA billing and payment system is fully transitioned into LTSS, we will continue to operate in 2 systems, meaning the LTSS Maryland system and our legacy PCIS system, our Provider Consumer Information System. Person-centered plans for participants will be completed and approved in LTSS Maryland as they currently have been. And services will continue to be authorized and billed through PCIS 2 until those services or providers are transitioned. Next slide, please. So for Appendix B, participant access and eligibility, go to the next slide, please. You're going to see that we've updated information related to eligibility. You're going to see language has been updated. Language has been reorganized for better information and understanding. You're going to see updates to our specific target criteria for each of the 3 waiver programs. And then you're going to see some slight updates related to information to reflect specific processes that are now being conducted in LTSS Maryland. An example here is that providers of our coordinators of community services receive alerts and LTSS generates reports related to the status of the annual level of care reevaluation that they complete. Previously, it referred to DDA maintaining outside databases and sending monthly reports. Next slide, please. In terms of some of the specific updates to the eligibility in terms of targeting criteria, we propose to remove the cost cap, the initial cost cap for enrollment for our family supports and our community supports waiver. You may recall when we were talking about the waiver initially that the family supports waiver has a $12,000 cost cap and the community supports waiver has a $25,000 cost cap. This means that if any applicant has a person-centered plan that exceeds those levels, they would not be eligible for those waiver programs. We are proposing to remove those cost caps at this time. In addition, we would like to focus each of our waiver programs for targeted groups. This means that our family supports waiver would then be supporting all children up to age 21. The community supports waiver will be focused to support individuals 18 years of age and older. We anticipate more of our transitioning youth to be focusing and being supported through the community supports waiver. Our community pathways waiver then would be focused to support individuals 18 years of age or older in need of residential services. The changes, once approved by CMS, will not change for any of the current participants. So all current participants, regardless of age, will remain in their current waiver program. This new eligibility criteria that we're proposing will only apply to new applicants as of the effective date of the waiver amendment. Next slide, please. As I mentioned, we will be making some updates to our program slots or the number of participants that are supported. In our waiver programs, we track the number of individuals that come in based on different, what we call reserved or priority categories. And based on the utilization over the last year, we've made some adjustments. We also want to increase our transitioning youth slots for the community supports waiver, as that waiver is now being targeted to support transitioning youth and adults who are not in need of residential services. Next slide, please. So let's take a look at Appendix C. Next slide, please. You're going to see that we clarified and reorganized language to inform individuals about the scope of the services. So an example here is you'll see that for assistive technology, this service includes not only a needs assessment, the actual acquisition or purchase of that technology, but also includes installation and instruction on the use of the technology and maintenance of that assistive technology. Next slide, please. To clarify specific regulatory references for service requirements, if applicable, we've also reorganized and added some additional language. So in this example, under our behavioral support services, specifically related to a behavior plan, if that behavior plan is restricting the participant's rights, then we wanted to clarify and inform that Title VII of our state statute and our Code of Maryland regulations will come into play and need to be incorporated in that plan. So the needs for those restrictions must be in accordance with our applicable regulations and policies governing participants' rights, behavior plans, and positive behavioral supports. Next slide, please. Another example related to clarifying this, not only what the scope of the service or the purpose of the service, but also to talk about what's incorporated or part of that service in terms of the supports being delivered. We've reorganized language to reflect similar language as this. So under our community living enhanced support service, you'll see the statement that the waiver program service includes the provision of the direct support staff, so the direct support professional, provision of the services, but it'll also include other services in combination or incidental to that service, such as transportation to and from and within that service, delegated nursing tasks based on the person's assessed need, behavior support services based on the participant's need, and personal care assistance based on the participant's assessed need. Next slide, please. So this is an example related to another, for our services for direct support, specifically in terms of additional services that may be incorporated. So if direct support staff perform our delegated nursing task as part of the program service, then we're noting that the participant must also receive that nurse case management and delegation service under the program, and that the delegated nursing task provided by that direct support professional must be provided by a person who has current certified as a Medicaid technician by the Maryland Board of Nursing, and that the delegated nursing task may not comprise the entirety of the services. Next slide, please. We also clarified and reorganized language to inform other examples. So specific to updates in terms of our transitioning to LTSS fully, we had specific dates targeted in our waiver currently. And so what we want to do is update those to reflect until the service transition into LTSS Maryland, that service would include whether daily units or hourly units. So as opposed to having an effective date, let's say of July 1st of 2020, you'll see we struck that language and just noted until the service transition. We've also updated references to nursing services as we are proposing to consolidate our nursing services under one service that I'll talk about in a minute. Next slide, please. We've also added some additional language related to staffing levels. Staffing levels are based on level of service need, which is the current phrase that we have in our waiver program, but we wanted to provide some additional information to clarify the different staffing ratios and groups. So under our community development services, as an example here, you'll see that we have language that states the level of staffing and meaningful activities provided to the participant under the waiver program service must be based on the person's assessed level of service need, and based on that assessed need, we may authorize a 1-to-1 and 2-to-1 staff to participant ratio. Next slide, please. Another example related to staffing level of service need is noted here related to our residential services. And so you'll see that we have similar language that the level of staffing and meaningful activities provided to the participant under the waiver program service would be based on the person's level of service need. And based on the assessed need, dedicated hours may be authorized for 1-to-1 and 2-to-1 staff supports. In addition, through input from our policy development and work groups, we had some recommendations to provide some flexibility for individuals who may not need 1-to-1 services, but may need some supports in the residential home with some others. So based on that, we're proposing to add additional language that states dedicated hours can be used to support more than one participant if it meets their assessed needs and the following requirements are met. 1, the participants are retired transitioning from one meaningful day service to another, recovering from a health condition, or received less than 40 hours of meaningful day services. 2, support is documented in each participant's person-centered plan and the provider implementation plan. So in other words, stating that they would be sharing that staffing. And that 3, that those dedicated hours are billed for only one participant. We're hoping that'll provide some more flexibility for our providers and staffing that would meet the needs of the individuals. Next slide, please. Under our self-directed service delivery model, you'll see we added language related to whether a relative or legally responsible person or legal guardian is providing the direct services, and that a written agreement would be used to identify people beyond the family member who would support the participant in making his or her own decision. We received some feedback and some input from some of self-directed advocates related to having more flexibility for the individual to identify through a written agreement who they would like to receive their supports. And so we've added some language in the waiver proposal. Next slide, please. In terms of remote supports, so you may be familiar that under our Appendix K Emergency Authority, we added the option to provide remote supports. And so based on the service experiences and input from our stakeholders, we are proposing to incorporate that into some of our services. The remote supports may be used in combination with in-person direct supports, that the remote supports should not isolate the person from the community or interacting with people without disabilities. The remote supports should be agreed to by the participant and their team and must not be used for the provider's convenience. Next slide, please. As per our current requirements under Appendix K, remote supports must be delivered using a live, real-time audio-visual connection that allows the staff member to both see and hear the participant, and the remote supports must comply with the requirements of the Health Insurance Portability and Accountability Act and all applicable regulations to protect the privacy and security of the participants' protected information. And lastly, that the remote supports must not comprise the entirety of the services. Please note, as I mentioned before, the Appendix K authority that we currently have and the options available in that will still remain in effect until the Appendix K ends in March 12th of 2021. And we are adding these requirements that would continue after the Appendix K ends. Next slide, please. Also under our Appendix K authority, we currently have the ability to provide some of our services and supports during a hospital or short-term stay. And so we'd like to add this opportunity to our waiver program. This is a new option that came available under the Corona Aid Relief and Economic Securities Act, or the CARES Act, that was signed into law that allows waiver services to be provided in hospital settings under specific conditions. So you'll see that we've added language that notes direct support professional services may be provided in an acute care hospital or during a short-term institutional stay for the purpose of supporting the participant's personal, behavioral, and communication supports not otherwise provided in that setting. The services may not duplicate hospital or short-term institutional services. You'll see that we added this language under our community development services, rehabilitation, personal supports, supported living, community living, both our group home option and our enhanced supports, which is also noted in our Appendix K. Next slide, please. In terms of nursing services, as we've mentioned during the Friday webinars, we're proposing to consolidate our 3 nursing models under one service. We have found that we get questions about which model should be used at which time, and so we feel by having one nursing service that incorporates the option of the 3 models will help to clarify and streamline our service and minimize any confusion. So what we're proposing is to maintain the service title of Nurse Case Management and Delegation Services as the comprehensive service, and within it, individuals could receive the nurse consultation or the nurse health case management or the nurse case management and delegation services. Next slide, please. In terms of our employment services, we've received some recommendations that we are proposing to become effective July of 2021. Specifically looking at our employment services for job development, ongoing job supports, and follow-along supports to be moved to a value-based outcome payment strategy. What this means is we're looking at job development transitioning to a one-time job placement milestone or upper payment limit, and also looking at all our supports following job placement to be provided under follow-along supports, meaning ongoing job supports and follow-along supports would then be merged. Next slide, please. The follow-along supports would remain a monthly payment with 3 different payment levels. These 3 levels are based upon the number of compensated hours for the participant per month, so the hours that the participant is actually working, and considerations of significant support needs. Significant support needs given up front and throughout the employment process. And so we want to recognize that some individuals with those needs may need additional level of reimbursement. And so participants who have a health risk screening tool score of 4 or higher or behavior plan would be considered to have a significant support need. Next slide, please. So let's talk a little bit about what you're going to see in Appendix D related to participant-centered planning and delivery. Next slide, please. You're going to see that we've updated language and we've also reorganized information for better understanding. You're going to see information that we are going to be utilizing certification of our coordination of community service providers instead of licensing them. And you're going to see some updates related to the LTSS transition in terms of that person-centered planning. Next slide, please. So specifically during our transition period to LTSS, that person-centered plan detailed service authorization section will identify our waiver program services in LTSS that meets the individual's goals, needs, and preferences. Once those services are selected, the cost detail tool is completed, which lists the comparable legacy services that are available through PCIS, including the amount, duration, and scope of the PCP plan year. Next slide, please. So for new participants with no service provider selected, the coordinator of community services will complete that cost detail sheet so that we can authorize services within PCIS2. For individuals with selected providers, the provider completes the cost detail tool and submits it to the CCS. For individuals using the self-directed service delivery model, the CCS completes the cost detail tool in addition to the self-directed budget with input and facilitation and direction from the participant. After the CCS reviews and confirms with the individual the cost detail tool meets their needs and preferences, they upload it into the PCP documentation section so that it is then included and part of the PCP submission to the regional office through LTSS Maryland. Next slide, please. So let's talk a little bit about Appendix E related to our participant direction or self-directed service delivery model. Next slide, please. You're going to see some updates and reorganization of information for better understanding. You're going to see we added employer authority as an option under our participant education, training, and advocacy ports. You'll see some updates related to the involuntary termination of participant direction, such as the participant's person-centered plan and or self-directed budget has not been submitted to DDA for review and approval in a timely manner, and this failure is attributed to the participant or their designated representative. This would be one of the reasons that we would review to consider whether or not the model was appropriate. If there was a delay for the budget approval or the plan on behalf of DDA or the FMS, that would not be considered associated or attributed to the participant or the designated rep. It would not be used as a reason to consider for changing the service model. Next slide, please. You're going to see we updated some information related to the participant-directed budget process. Specifically, this approach will be used for determining the participant's self-directed budget until the budget process is fully transitioned to the LTSSMaryland Detailed Service Authorization process. So the process will follow the steps. The coordinator of community services and team will assess the needs of the participant through that person-centered planning process. The CCS and the team will develop a person-centered plan to meet those needs and service requests. These are expressed in service units and cost reimbursement services. Next slide, please. The CCS will complete and submit the DDA cost detail tool with the PCP. This cost detail tool includes all available services and associated rates based on the traditional service delivery model. Annually, if approved by the General Assembly, the DDA applies a cost of living adjustment, known as a COLA, to traditional service rates, which is updated in the cost detail tool. The required use of the cost detail sheet for both participants using the self-directed and the traditional service delivery models ensures fair and equitable funding regardless of service model chosen. Next slide, please. The CCS will submit the person-centered plan with a cost detail tool to the DDA regional office for approval. Once the PCP and cost detail sheet is approved by the DDA, the participant can then create or finalize their self-directed budget sheet and determine pay rates based on reasonable and customary program standards. That information is then shared with the FMS. Next slide, please. So effective January 1st, 2021, during the initial, revised, and annual PCP planning process for participants using the self-directed service delivery model, the participant's self-directed budget will be determined based on the approved LTSSMaryland PCP Detailed Service Authorization. The LTSSMaryland PCP Detailed Service Authorization form includes, again, all the services and associated rates based on the traditional service delivery model. The required use of the LTSSMaryland PCP Detailed Service Authorization section for participants enrolled in our self-directed and traditional model, again, will ensure that fair and equitable funding regardless of service models chosen. Next slide, please. So the Appendix F relates to our participant rights. Next slide. So you're going to see just some minor updates related to language being organized within this section. For instance, you'll see that we've moved some language up or down in the sentence. So related to receipt of funding services in terms of decisions, the department will provide a written letter notifying the individual if adverse decisions, including our notice for Medicaid fair hearing rights, as further described, and that a copy of the final and signed notice will be retained in the individual's file in LTSSMaryland instead of being retained in an outside file system. Next slide, please. For our participant safeguards in Appendix G, next slide, you're going to see again some slight updates in language where we may have reorganized the sentence. An example here is any method or technique that deprives a participant of any basic rights, as noted in Health General article or applicable law, such as access to a telephone, right to share rooms with a spouse, visitors, access to clothing and personal effects. the ability and right to vote, hold or dispose of personal property, or receive services except as permitted by our regulations. Next slide, please. So for Appendix H, next slide, you're going to see, again, this is a very small appendix and just some minor updates in terms of language, specifically capitalizing the word waiver program. So as an example here, the DDA Quality Advisory Council is composed of various stakeholders, including waiver program participants, family members, providers, advocacy organizations, and state representatives. Next slide, please. So now I'm going to turn it over to Valerie to talk about Appendix I and Appendix J. Valerie?
Thank you, Rhonda. So good morning. So as we start to talk about Appendix I, there are a couple of comments I would like to make. First, I'd like to take a moment to point out that the rates included in Appendix, well, I'm talking about J, but I and J go hand in hand. One really includes an explanation of the rates, and J really shows you the dollars. But Appendix J, the rates that you see in Appendix J are really average unit cost and are not the specific rates for each of the services. So I want to make sure that folks understand that, because otherwise it can be confusing. So we've included some charts in this presentation showing the rates, the new rates for the new services as they stand now. The rates differ from those shared in October of 2019. Most of the changes are the result of the feedback and input received from the technical work group. Based on the comments that we will receive during this public comment period and from DDA's continued input and work with the technical work group, these rates may be adjusted in the future. Next slide, please. So this is goes back to Appendix I, which again includes the explanation of what is DDA's methodology for the rate development, but it also includes sections about accountability. How are we managing? How are we ensuring that the rates that are being paid, that services are being provided? But it is also in this section where we have to add some additional language about the other changes we are making. So one of the first changes we're doing is adding a geographic differential for the counties of including Calvert, Charles, Frederick, Montgomery, and Prince George's County. We are also changing the hourly service units from 1 hour to 15-minute billing increments. This will allow for better billing flexibility. We are also changing the monthly unit for living caregivers, support broker services, and employment services co-worker employment supports to an upper pay limit as opposed to a static monthly payment. Next, please. Appendix J. Next slide, please. Again, as I mentioned, this is just some accountability updates. This is where we update the rates. This is where we update the units and also the user estimates. How many people do we think are going to be using this service? And CMS uses this information to get an estimate of cost. How much are these services going to cost in the state of Maryland? We have also added information for the job development milestone and for the follow-along performance value-based payments. Next, please. So the first slide we have in our chart is for the meaningful day services. This slide shows the rates for community development services, day habilitation, employment services, and career exploration. You will notice that the billing unit for CDS, day habilitation, and career exploration has been adjusted from the previous 1-hour billing unit to the proposed 15-minute billing increment. As I mentioned previously, this is proposed to allow for better and improved billing flexibility. I'd also like to point out that job development has been revised or is proposed to be an upper pay limit with a maximum of 60 hours of service. As Rhonda's mentioned, DDA is also proposing to consolidate follow-along and ongoing support services into follow-along services effective July of 21. The rate in Appendix J and in this chart of $500 is a placeholder. The DDA has contacted SELN and the Employment First Workgroup for input on the rate. Next, please. This slide shows rates for the support services. Again, those services that were previously 1-hour billing units, such as the housing support services and respite services, have been adjusted to reflect the 15-minute billing increment. Services like behavioral consultation and personal supports are currently billed at 15-minute increments, so there is no change to those billing units. Next slide, please. This slide and the slide on the next page are all represent residential rates. So these rates do differ from those in October. There has been some adjustment based on some discussion with the tech work group. I also would like to point out that the billing increment for dedicated hours for community group home and dedicated hours for community living enhanced have been adjusted again from that 1-hour billing unit to a 15-minute increment. Next slide. Here we have the other residential rates for shared living and supported living. And here again, you will notice that the billing unit for dedicated hours for supported living has been adjusted from that 1-hour increment to a 15-minute billing increment. Next slide, please.
Thank you, Valerie. And now we're going to share some information about the public comment process. Next slide, please. So the official public comment period is from September 1st through September 30th. You will note, if you had an opportunity to check, that track change documents regarding the amendment proposals are available on each of our waiver programs' dedicated Amendment Number 3, 2020 pages that are listed on our next slide. As we have done in the past, we're asking for public comments to be submitted to our dedicated email account, wfb.dda@maryland.gov, or they can be mailed to the department, to DDA Federal Programs at 201 West Preston Street. As we've done in the past, we're encouraging you to submit your comments. They will be considered for all 3 waiver programs. So therefore you can submit one set of comments and input versus doing one specific to each waiver program. Next slide, please. These are links to dedicated pages on the DDA website for each of our waiver program. When you click on these links, you'll go to a specific page that'll include the various appendices, A through J, and also have the specific track change documents that you can review. Next slide, please. In terms of our next steps, we are in the public comment period. We will be reviewing input and updating the proposals based on the input that we receive. The final proposal will go to Medicaid for their final review and approval. This is Medicaid within our department. Then we will be submitting to the Center for Medicare and Medicaid Services on November 1st. CMS has a review period time frame, so we're proposing the review November through January, and we will be proposing an effective date of January 1st for these amendments. Next slide, please. This is information related to our regional offices in case you need some assistance related to services or supports currently or eligibility. And so we wanted to make sure that we provided information related to each regional office, the director's name and contact information in associated counties if you need some supports outside of our amendment discussion today. Next slide, please. And now we'll open it up to questions.
Thank you, Valerie and Rhonda. Really appreciate you guys doing this. I'm going to start reading some questions. I'm going to start with Valerie, since that was the last piece of presentation that folks had. So Valerie, there's a couple of questions to ask you. Does the average include the geographical differential?
Yes.
Okay. For meaningful day they have, can we now switch between small and large group through the day?
I think I'm going to ask Rhonda to address that.
Yeah, so at this point, we are pursuing changes within the functionality so that an individual could receive both small and large group supports during a single day. So that functionality is not currently in the system, but that is something that we are actively pursuing and working with the vendor to have corrected and changed and flexible.
Will personal supports rates that were just shared be the rates that will be in effect when providers transition to EVV in billing personal supports through LTSS Maryland?
At this time, these are the rates where they stand currently. Again, we have this public comment period, and depending on if there are other comments, there may be some changes in the future. But as of today, these are the rates, and if there are no comments and DDA moves forward, then these indeed would be the rates.
Valerie, do you want to share what counties include the geographical differences?
Certainly. It's Calvert, Charles, Frederick, Montgomery, and Prince George's counties.
Thank you. The other ones are Appendix I. The amendment indicates a proposed implementation date of 1/1/2021. Are the new rates and new guidelines going to be implemented at the same time if approved by CMS?
So what that means is that CMS will have approved it. And as we move forward, again, we've talked a good bit about where we are currently in terms of our IT system and the transition from the prospective payment to the fee-for-service. My response is that we will be running dual systems for the foreseeable future until we are fully implemented into LTSS. Until then, these will be, at that time, these rates that have been included in this presentation, pending any future changes, would be the rates that would be incorporated into LTSS, and those would be the rates that would be paid to service providers.
Thank you, Valerie. I'm now going to move to specific waiver amendment questions. What is the difference between certification versus licensing, and what services are listed and which are certified?
So that's a great question. And so I would refer you to Appendix C, where we have the specific services. And within that, we'll talk about provider qualifications. And so what DDA did through, I believe, either our renewal or amendment number 1, is that we clarified that services that require licensing are services that are provided at a provider owner operated site location. So for example, our residential services, referred to as community living group homes, are provided at a specific site that is licensed by the Office of Healthcare Quality. In addition, our day habilitation services, absent this pandemic, are provided at a licensed site, a building that is owned or operated by a provider. And those services for day habilitation would require licensing. Services that can be provided in the community or in different settings, such as personal supports, respite services and environmental assessments and such are not site-based specific services owned or operated by a provider, and therefore those providers are certified. So in terms of our coordination of community services that we've talked about today, coordination of community services is not a specific site location where they deliver services. They meet individuals in their own homes, in the community, and other areas. And so we are changing through the Targeted Case Management State Plan Amendment, the licensing to be a certification versus a license requirement.
Thank you, Rhonda. The next one is, this all has to do with some of the personal supports questions. So if two people in the home currently have ILOD and each has a one-to-one, on page 21, it states dedicated hours can be used for more than one person. Can that occur in this case where two people under ILOD use one staff?
So I think what we're talking about, ILOD, I think refers to in lieu of day services. And what we're talking about in terms of our residential services, so this is not personal supports, this is residential services, but the direct delivery of supports that could be provided, dedicated supports during meaningful day, typical hours, we are proposing, based on the requirements being met in the proposal, that you would be able to use dedicated staff to share among multiple participants in the home if, again, the participant is either retired, transitioning from one meaningful day service to another, could be at home for a limited amount of time recovering from a health condition, or is receiving less than 40 hours of meaningful day services. Again, it would require supporting documentation in each of the participants' person-centered plan and the provider implementation plan, and that it is the choice of the participant and will continue to meet those needs. The hours that would be billed could only be billed for one participant. It would not be billed for both of them through our LTSS system.
This one is if there are 3 individuals in a residential unit sharing one staff, are we supposed to only show that one individual is receiving supports when billing? In this, we probably need clarification. Is it supported living you're talking about, or is it residential community living? But that's the question, Rhonda.
Yeah, and so one thing to keep in mind right now, if we have authorized through the pilot program dedicated hours or through PCIS2 dedicated one-to-one hours or wake overnight hours specific to a person, then those hours must be provided to that person and cannot be shared unless otherwise authorized through our Appendix K emergency authority. So what we're proposing in the amendment is to be able to provide some flexibility for situations where people are not engaged in a meaningful day activity because they're retired, maybe recovering from a health condition, and they're at home, and that maybe there's 2 housemates at home, being able to use some dedicated supports to support both those individuals instead of requesting dedicated hours for each of them and requiring 2 staff to provide one-to-one staffing for individuals.
Here's one on page 34 of the slide. Can we make it clear that CCS providers are considered part of the submission to DDA? Failure of the CCS provider to promptly and timely process necessary forms is not a fault of the participant. And we do know that, and that is very clear that we want to make sure that CCS are an extension of the DDA system, and so we want to make sure that we start counting everything once the DDA gets it in at our office. This is a nursing question. Is the plan of nursing to be add on for all waivers with the 15-minute increments? How is this determined, and how many nurses hours are included versus how many are needed?
So that's a great question. And so nursing, a couple things to keep in mind for nursing services. Number one, we have nursing services as components of some of our other services. For example, our community living group home services already include nurse case management and delegated services based on participants' assessed need. So in the rates, there is a component related to those supports that have been incorporated into those rates. As we have currently approved in our waiver today, if additional nurse delegation hours are needed because an individual is coming out of a hospital or a rehab stay and their staff need new or additional training, then requests for additional standalone nursing case management and delegated service hours can be requested and approved based on assessed need. All of our nursing services are provided in 15-minute increments in terms of being a standalone support service. So for those services that include nursing as part of a component of it, in addition to the residential supports or meaningful day supports, you would not be billing for 15-minute increments for nursing services unless they were additional specific standalone support hours added because of a person's change of health condition exiting a hospital or rehab stay. Under our, yep.
Go ahead.
I was just going to say, under the standalone nursing services, those services would be authorized based on assessed need, and the standalone services would be billed based on 15-minute increments.
Thank you. There's about 4 questions about participants' eligibility criteria. Does it remain unchanged? Is that correct? And then with regards to the proposed caps, when the caps are removed, what would happen with the eligibility criteria? Can you please provide more clarification on the eligibility criteria?
Sure. So Appendix B is the section where you're going to see information about the eligibility. And so we've updated and reorganized the language to be clear in terms of our targeted groups of individuals that we're supporting. Once the cap is removed for the family supports and community supports waivers, that will have no effect, excuse me, it'll have no effect on participants currently enrolled in the programs. As a matter of fact, through our previous amendment, we had removed the requirement for that annual cap. The cap is right now only required for initial enrollment. Once a participant has been enrolled in our cap waivers, they can continue based on that program meeting their needs. So with this proposal, we want to remove the caps altogether, and individuals will continue to receive services in those programs. The other part that we're proposing is to focus the 3 waiver programs that the DDA administers on behalf of Medicaid to support specific targeting groups. Family Supports Waiver will be used to support all the children that come to us that are in need of services based on meeting eligibility criteria. The Community Supports Waiver will support individuals 18 years of age and older in need of meaningful day or support services. And then the Community Pathways Waiver will be targeted specifically to support adults 18 and older who need residential services. They can receive also meaningful day and support services, but only new applicants upon approval from CMS will be based on having a required need for residential services.
Thank you. There's some more questions that are popping in. I'm going to still stick to the waiver amendment and then we'll move over. Can you clarify which services include transportation versus which we can request transportation funds to supplement?
That's a good question. And so within each of the waiver services, as I mentioned, we've added clarifying language to note whether it includes a direct support staff, whether it would include delegated nursing task, and whether it included transportation supports. So we do not supplement transportation services. If transportation is a component of a waiver service, then that would be a component of our BRIC and our rate and incorporated in that. Our standalone transportation service is used when individuals are utilizing or needing supports to transport or move within their community. It could be mileage, it could be an Uber, it could be a Lyft, it could be other prepaid cards in terms of independently using transportation community services within their own community. So if a participant needs a staff person to be with them during transportation to provide some direct supports beyond the actual transportation, then that would be considered a different service, such as maybe community development services or personal supports.
Okay, I'm going to now move to all the questions in reference to self-direction, but there was one, Rhonda, can you clarify a little bit? I think people are getting confused between removing the cap and eligibility, and now they're asking what is the cap for the community pathways waiver?
Yeah, so that's a good question. The community pathways waiver has never had an initial waiver application cap. For all waiver programs, there is something called cost neutrality standard, which means the total cost for the services for the program cannot exceed the cost for those services in an institution. Medicaid waiver programs are an alternative to institutional care. That's why we have to assess that applicants initially and continually meet the need for an institutional level of care of services, because a waiver program provides an opportunity for states to provide services in the community where they would otherwise provide services in an institution. So there is no cap associated with the community pathways waiver in terms of waiver enrollment, but all waiver programs must be cost neutral. We cannot cost the federal government more to provide services in the community than they would pay to provide services in an institution.
So I just want to let the audience know that I'm reading things as they come to. Know that I'm going to go back to Valerie after we finish the self-direction with the additional questions posed directly to Valerie. So let me move over to some of the self-direction questions, and then we'll go back to Valerie. So this one is for the self-directed participants being supported by family members. Would a support broker or CCS qualify as a non-related person? And if not, can you describe how this will work?
So that's a good question. Two things I would state. Currently in our waiver program and as per federal requirements, we have to ensure conflict-free case management and conflict-free services. Therefore, a support broker and a case manager would not be permitted to provide direct supports, other services to a participant other than that support broker services or case management services. The only exception is under Appendix K, our current emergency authorization because of the COVID pandemic, in which we provided and received approval to have temporary flexibility for a support broker to also provide direct supports. Once the Appendix K authority ends, which is set for March 12th of 2021, that option and opportunity will no longer exist because it remains to be a conflict related to services.
Thank you, Rhonda. This one is, if remote supports are given during personal supports under self-directed services, how will EVV work since the direct support is off-site providing support to participant?
So in terms of EVV and remote supports, there will be additional information that comes out. It has been shared with our providers currently, our pilot providers, but what will happen is a note will be indicated in the EVV system. A manual entry would be logged for the services that are provided remotely to note that they're COVID related, because the individual, the staff would not be calling in using the OTP, the one-time device, or the participant's phone. And so it will be a manual entry with a specific note related to the COVID situation.
All right, and then there is one about family supports. Folks want to understand and know, based on this amendment, what would be the criteria to having a minor child under 18 to move from family supports to residential services, to move to the comprehensive waiver.
So our residential services and the criteria established in terms of accessing them are all noted in the community pathways waiver. So we would be looking at assessed need, we would be looking at the situation, we would be looking at cost effectiveness. And so for each of our residential services, included our supported living, our shared living, and our community living, group home, and our community living enhanced supports, there's specific criteria that would need to be met in order for that to be considered.
All right, now I have lots of questions that are not really related to the amendment, but is related to some processes and some specific questions. So let me roll over to Valerie. Valerie, I'm going to ask you a couple of questions, and then I'm going to do other that is not about the amendment, but it does impact based on some of the questions. So Valerie, when will the true rates be published for providers to see?
So what I would say at this point, as I've said before, these are the rates as they stand currently. As I said, during this public comment period, we will see what comments we get to see if there are any adjustments that DDA wants to make. We are also continuing our work with the technical work group, and we'll be getting additional feedback and input from them. Once we get through that process, we would again take the opportunity to issue or to show in a public way what the rates are at that time. Rate development really is not a static process. As services change, and as our working environments change, much like we are in the middle of COVID, this could also impact rates in the future. However, we are, as I said, these are the rates at this point in time. I think we will have a better understanding after the public comment period has concluded.
And then there's one more for you, Valerie. And has the DDA created rates for the organized healthcare delivery services, OHCDs, that allow for a provider to get an administrative rate for assisting families to arrange respite, transportation, supports, etc.?
Yes, DDA is in the process of finalizing that policy, and we hope to have it out within, certainly by the end of this month, if not sooner.
So the policy is finished. We're just adding the rates to that, right, Valerie?
Rates and the information around the process.
Great. And I'm going to flip back one to waiver services. There's a question if rehabilitation allowed in community supports waiver, because last year when they took one new transition youth, our only option for them was supports waiver, and the DDA would only approve CDS.
So I think a couple things to keep in mind for families and providers. In order to provide meaningful day services under the community supports waiver, you need to meet the community settings requirements. And you need to apply to make sure that you're eligible and either certified or licensed for that program. And so when we initially started up some of the new waivers, the family supports and community supports, particularly the community supports for some of the transitioning youth, some of the providers were not certified or approved, excuse me, to provide that service. So it's important as a provider to make sure that you have been approved and you meet the requirements for the community settings rule under the community supports waiver. And if you're a new provider, that would be required also on the community pathways waiver.
Okay, and this is a programs question, and it's also a operations questions, but I'll read it and we'll let Rhonda respond first, and then if Valerie, you want to add anything to this. Regarding person-centered plans, how is the Developmental Disabilities Administration addressing the backlog in providing plans prior to the electronic visit verification implementation? So Rhonda, do you want to answer what we're doing? And then Valerie, would you like to add to that after Rhonda? Go ahead.
Sure, absolutely. So we have a plan and strategy in place that is already in implementation that we are going to review all person-centered plans for participants who are authorized personal supports to ensure that they accurately reflect the services and the assessed need, and to support the phase-in implementation of our regional strategy before the go-live date. So we are actively working with our coordinators of community services. We have provided them with a list of the names of people with personal supports and coordinating with them in terms of review of those person-centered plans. In addition, we have been working with the provider tech group. We have been working with our coordinators of community services agencies in the use of and development of a new tool. We're referring to it as the Detailed Service Authorization Tool, which will help to communicate and support the specific service and units and months to be recorded in the LTSS PCP authorization section so that we can ensure accuracy and that it meets the participants' assessed need and preferences. So we are already in the works of doing that, but again, we will review all participants with personal supports as person-centered plans to make sure that they are accurate and available, and billing can occur through the electronic visit verification system. Valerie, if you have anything you want to add?
No, I think you really covered it, Rhonda. I think that I would just take it one step further to indicate that as DDA is monitoring the PCP process, we are also coordinating with our Medicaid partners. So we are trying to approach this implementation in a comprehensive way to make sure that all the pieces that are necessary to a successful rollout are indeed in place.
Okay, now I'm just going to go directly to the chat and just read things that popped in since I've cataloged the questions. So there is a lot of questions about that are not related to this, but is about provider applications. Is there a moratorium on provider applications? And the answer is no. What we're doing is for new applications that are coming in for new providers, we are accepting them, but we're not going to be reviewing them until January. Because we're prioritizing making sure that our current existing providers are in the ePrep system. They're currently have all the proper codes and everything set up to be able to roll out everything that we're doing. So we are accepting applications, but we are not reviewing new applications until January. Then there's a couple of other additional questions in reference to the FMS and what is the role of the FMS effective January of 2021. So it says for Sept direction, what is the role of the FMS provider as it relates to the utilization of LTSS Maryland come January 1st, 2021? Valerie, would you like to answer that?
Certainly. So currently, the FMS agencies are paid through our legacy system, PCIS2, and that will continue. We have not moved the FMS into LTSS. That will be done much further down the road. So they will continue to use the legacy system. I'm not sure if that answers the question, but as of right now, there is no change in the foreseeable future in terms of the interaction with our IT platforms.
And Valerie, there's some more questions on here, but I need further clarification to read it. So let's see if this reader will put clarifications. They went into the DDA website, and under the rehabilitation rates are considerably lower, and why. But I don't know if they're looking at the Excel sheets that how we develop rates right now through our system, or they're looking at the December authorization and billing guide, or they're looking. So I'm not sure what this person is asking for, but it has to do with rates. So if something pops up on the chat, I'll reread it again. I just didn't want you to, I wanted to make sure you knew that this was on there. There's other questions not related to the amendment specific, but just about who reads the public comment, Rhonda?
Oh, that's a great question. So my team, I have staff within my program unit, the federal programs unit. We have the dedicated email account and anything that we receive in writing. We read all the comments. We will organize the comments in terms of similar comments. So if 3 people suggest the same thing, we're going to consolidate them. We will kind of phrase them so that they're very specific in terms of the input. And we will then share that with subject matter experts, have dialogue internally, and then make decisions related to the input we received. We also log all the comments that we get in terms of the individual who submitted them and the date that we received them.
And then from there, what happens?
And then from there, once the final decisions are made by the Deputy Secretary, we will post on our website, as we have in the past, a summary document of the public input received. It'll note the a summary of the input, specifically the department's decision, whether we accepted it, revised it, or did not accept it, and then it'll have some details about the reasons why.
Okay. Rhonda, can you expand a little bit about what happens to remote services between late March when the Appendix K is no longer in effect, but this amendment is not yet in effect?
So that's a great question. So a couple things to keep in mind. We're asking that this amendment to become effective January 1st of 2021. And so therefore, it will be in effect before the expiration of Appendix K. If there is more flexibility under the Appendix K, such as the example of the support broker being able to provide direct supports under Appendix K authority, or other flexibility for remote supports under Appendix K, then that would be able to be continue to be provided until Appendix K ends in March 12th of 2021.
Thank you. Donna, can you please put on the screen slide 54? A lot of people are asking the public period, when does it, how long do they have, and where to send the information to. So if you can just make sure, just leave it on that slide. So hopefully we'll answer some of the questions that people have as the dedicated email, and also the public comment period open from September 1st to September 30th. Okay, hopefully that answers those questions. And then there is several questions, Valerie, Rhonda, there's probably 15 about the self-direction 4% COLA that has nothing to do with this amendment. Valerie, would you like to address that?
Certainly. So the COLA is applied to traditional services, and the budgets for people in self-directed services are developed based on those traditional services, those rates. Consequently, the rates already include the 4% COLA that was applied effective July 1st, 2020. So individual budgets do not get the 4%, but it is applied to those services, and those services, the rates for those services are used to develop the self-directed budgets.
Thank you. Rhonda, do you want to talk about, once that's done, how is it done through the PCP process?
Yes, so what we've put on our slides is effective January 1st, when there is a initial revised or annual PCP, the LTSS detailed service authorization section, which will have the final rates included in that, will then establish the self-directed budget based on those assessed need for services. And then the participant, with the support of their team, can use that budget based on the assessed need for services to create their self-directed budget and then assign pay rates and such as per the authority under the self-directed model noted in Appendix E. That self-directed budget then is reviewed and approved and moves forward. The FMS then would be implementing that using the pay rates as per the participant noted in the budget.
Okay. I think this one I might have already read for you, Valerie, but it had to do with personal support rates in the EVV and people moving to supported living. And they wanted to know what would be the guidance for that.
So the guidance, as always, if an individual currently is in personal supports, as their PCP is updated or at their annual meeting, certainly if the individual, if the supports that are needed align with supported living, then we would expect that they would transition into supported living as we move forward. We very much want people to be in the appropriate service models so that they are getting the supports that they need to meet their desired outcomes.
Thank you, Valerie. It is now 11:21. I don't see anything else in the chat box. Some that were specific. Oh, there's one more that came in, and this is specific to Rhonda. Do you foresee the virtual supports outside of independence? No, we already did that one. So we already answered that. That's it. So I'm going to wait about another 2 more minutes and see if there's anything comes up on the chat box. And then we'll end. So let's see. Please clarify, what documents should self-direction participant use to see the maximum rates to use to develop their budgets? That is great. So you would have the usual and customary rates, and based on the information that Valerie shared today, Patricia Sestoki, am updating the usual and customary rates with Natoya, and our goal is to post those on the website so that you will have that. And so we're everything based on the usual and customary rates. That was that question. The other one is the DDA is going to be providing training on the cost detail sheet and also on their service detailed service authorization. And we're hoping to do that in the next couple of weeks. So we'll give you enough announcements and information for people to be able to join us to learn how to use those different tools. Okay, as I'm speaking, 8 different things came in. So let's see. Currently in PCS 2, transportation was rolled over from FY 2020 to FY 2021. Does it mean we cannot bill for that fiscal year 2021 under personal supports?
So if the service, go ahead, Valerie.
Valerie, go ahead, and then if
okay, all right, sorry. So services that are paid through the legacy system will continue to be paid as they have been in the past. So if an individual is receiving personal support services and billing for transportation services, that will continue as long as they are in and being paid through the legacy system.
Yeah, and I agree. Once the service transition into LTSS, then transportation is a component within personal supports, and then therefore it would no longer be a standalone separate billing.
This one is, some individuals and self-directors have an actual budget that is lower than the rates in the cost detail sheet. Will their budgets be adjusted, increased when the amendment takes effect in January?
Yes.
Okay. Some are now just comments, they're not questions. Here's a question. For participants that cannot own or lease their own home for supported living services, how can they receive supervision staff during sleep hours?
So there's different service models to meet different needs. And so when you think about the participants' needs, you'll want to explore the different options. We offer drop-in supports that are personal supports to be habilitative. They're not for supervision overnight. We do have our supported living services and our community living and shared living that provides more services that could include overnight supports, such as awake overnight supports. So you really need to look at the assessed needs of the individual and the options that are available. In general, we do not provide just general supervision for people during the night. So we're really looking at an assessed need, with the exception of our community living and supported living models where there is the opportunity to have those additional dedicated staff based on assessed need.
All right, I'm going to read this one again. This is the same person asking the same question but different ways. Maybe we're not capturing her question correctly, but I'm going to just read for what are plans for remote supports from March 2021 and on?
So with the approval of amendment number 3 from CMS that includes remote supports, as we've described in the waiver amendments, then March 12th, 2021 and going forward, then that would remain to be a service option based on the criteria and standards that we talked about today. They cannot be the sole service. It could be in combination with in-person supports. It needs to have the person's approval with that. It cannot isolate the person, and it cannot be done for the convenience only of the provider. So they would continue.
Thank you. Valerie, this is for you. This is what I asked a couple of times and I missed it. If DDA's budget stays the same for this fiscal year, will DDA pay 100% of the rates?
I am assuming, and that could be, I could be wrong, but I'm assuming that the individual who's asking the question is talking about the legacy system and the rates that are currently in PCIS 2. Again, as of right now, we have included the 4% COLA in the FY21 rates. Those rates are in PCIS 2 and are operational, and they will continue to do so unless there is some change in the future. But as of right now, we will continue to pay those rates.
All right, thank you. This one is more of a clarification. So in October, when EVV starts for the Western region, the transportation add-on will be eliminated and the provider will get the new rate for personal supports. Is that correct?
That is correct.
Okay. If there are no additional changes, the rates on the charts presented today will be the rates for personal supports beginning October, November, and December's transition. Is that correct?
That is correct.
Okay. I have 2 more minutes. Does that mean when personal supports transition into LTSS for EVV requirements, will providers be paid through LTSS or PCIS?
Providers will be paid through LTSS.
Okay. Will a person be able to change from a community supports waiver to community pathways waiver if the person later needs residential services?
Yes, we will assess the participant's need, and if they need residential services and meet the criteria outlined in the waiver program, then we would help to facilitate the application to the community pathways waiver.
Okay, this is my last question. It is, can people who live with their family receive supported living?
So supported living is provided in the participant's own home or apartment. It is not designed to be provided in a participant's family home. So the answer would be no. There are some unique situations where family members or participants have their own suite, like an in-law suite or a separate from the home. So those would be things we could consider, but if they're living with their family, it's not considered the supported living model.
Valerie, this is for you. I said that was the last one, but this one is, when will the other services go to LTSS?
The other services will go to LTSS when we fully implement the services and use of LTSS. Currently, our priority is operationalizing EVV in LTSS, and that is the plan for this fall through to January 1 of 2021. A schedule and a plan have not been confirmed for anything beyond that time at this point in time.
Thank you, Valerie. This concludes our webinar for today. Please make sure that you submit your public comments. We will review everything that we get and take it into consideration. So have a wonderful rest of the day. Thank you for joining us today.